Okay, please, doctors, let's join. Let us join. It's time so that we can begin. Okay, so if you have joined, please write your name. Let me know who is here. And I will start. All right, good evening, Saibi. Good evening, um, Aishat Haruna. Okay, one of my patients have joined the, the live session. Okay, but the name is not there. Okay, okay, okay. Three people are joining there. Ghanese, one, two. Okay, three of you. One phone. Okay, lack of light. Have you? I understand. Okay, so we have how like so we have how many people here? Please let's join. We okay. Eto we Dr. Ni Hausa nake ji zan iya tambaya. Eto rubuta tambayan ki. One of my faces is here. Rubuta tambayan ki amma a YouTube din ai ba rubuta ainihin sunanki ba ki faɗa sunanki tukuna kafin ki iya tambaya. Okay, let's wait for. Okay, Esther is here. That's good. Esther is here. That's good. Who else? Adetola is not here, but we will not wait for her. Because today we'll try and conclude on time. Mm, so today we'll be dealing with dermatology. Today we'll be dealing with dermatology. So as you people said, you send certain topics that have been taken in dermatology through your through Adetola. So I want to confirm whether you were taught or not. Latching planners is very important. Okay, Adetola is here. Welcome. Were you taught latching planners or liking or whatever? May I call it latching planners? Okay. Were you taught? Yes or no? Were you taught lesson planners? Okay, so Saebi say yes, sir. Okay, so let's answer some questions. Which aspect of the body is affected if someone has latching planners? Which aspect of the body? Is it the trunk? Is it the whatever? Which aspect of the body is affected when somebody has latching planners? Okay. Which aspect of the body has anybody answered me? Which aspect of the body is affected? If no idea, please type no idea. In kuna ji na patient ɗina Yusuf Muktar da Muhammad Awal, ku chatin ɗina zuwa anjima a TikTok. Ku je TikTok ku chatin ɗina zuwa anjima. Wannan bayanin da nake yi na likitoci ne ba na mara lafiya ba. Ko ku yi hankuri. Wannan ɓangaren na likitoci ne. Okay, so Saebi said no idea. Okay, so pay attention. Saebi, Adetola, Esther, Aishat Haruna, pay attention. Okay, so latching planners usually involves the extensor surfaces. You understand? Extensor, like here, extensor, not flexure, extensor surfaces of the limbs, especially extensor surfaces of the forearms, right? Extensor surfaces of the shin, right? So these are the places where it affects, and it's usually itchy. Okay, Abdullah Toro is here. Okay, so latching planus affects extensor surfaces. Okay, sorry. I think I'm wrong. I'm talking about psoriasis. Sorry. Please forgive me. Latching planus involves flexure. Aisha said it. Thank you, Aisha. So latching planus involve flexure areas. What I was talking about is psoriasis. Flexure surfaces of the wrists, of the forearm, of the shin, and also lower back. So latching planus is flexus is extensor. That's the major difference. Latching planus flexor surfaces, while psoriasis extensor surfaces. Okay, so please try and remember that. Okay, so let me go to the next one and see. Which one is this? I'm trying to get the ones that apply to you. Okay, this one doesn't apply. Mm, Okay, let me just go to where we can speed up things, or I will not waste time. Okay, so pay attention, please. If a young man, right, a young man, an 18-year-old presents to you with widespread pruritus, and he also has some lesions in the interdigital webs of the ribs, which are itchy, what is your likely diagnosis? So widespread pruritus, some lesions in the interdigital webs, and also sides of the finger. What is your diagnosis? Any idea? Please type the idea. Widespread pruritus, lesions on the finger, interdigital webs of both hands and feet, and the lesions are itchy. What's the diagnosis? Okay. Very good, Esther. Is scabies. If you hear pruritus, lesions in the interdigital webs, is scabies, right? If you hear interdigital webs, is scabies. Don't ever forget. Hmm? You know, every disease condition has a particular word that would give it out. Where is Wilfred? I thought he's part of this group. This is the second. I'm not seeing him. All right. So if you get lesion that is itchy, more on the fingers and feet, especially in the interdigital webs, is scabies. Please do not forget. All right. They may not give it out by saying that there is linear boros. But if you see linear burrows, fine, on the side of the finger. But if you just get itchy lesion into digital webs, that is scabies, right? So the treatment of scabies include use of melatonin, zero point 0.5 cream. You can use permethrin 5%, and sometimes if there is secondary infection, because it can happen, you can give antibiotic. But as long as there is no secondary infection, there's nothing antibiotic can do. So you know, people that develop scabies are people found in overcrowded areas, prisons, where hygiene is minimal, isn't it? Okay. So let me see what else. Were you taught skin disorders associated with malignancy? Skin disorders associated with malignancy, were you taught? Okay, did anybody answer me? Okay, so no, sir. Okay, so let's jump it. But for your knowledge, right, acanthosis nigricans, apart from insulin resistance from people that have type 2 diabetes, acanthosis nigricans is seen also in gastric CA. Gastric CA can give you acanthosis nigricans. So, next question. What are the, we'll just be going, we'll just be using it step by step. What are the possible bacterial cause of Steven Johnson syndrome? Bacterial cause, bacterial infection that can give you Steven Johnson's. This one, even if you are taught or not, you must know it. Steven Johnson. What are the bacteria that can cause Steven Johnson? If no idea, write no idea. If you have idea, please answer. Esther, this one is PDP now. Some Oreos or strips. Is streptococcus. Okay, strep can cause it. So strep and mycoplasma, they are bacterial causes of Steven Johnson. Okay. Then what else am I going to even ask you? Okay, how about viruses, Esther? How about viruses? Which virus has been implicated? Which virus has been implicated? Any idea? So let me just say it. The viruses that have been implicated are herpes simplex viruses. Herpes simplex virus. But for drug, all of you must know. So what are the drugs that have been implicated in Steven Johnson syndrome? Drugs implicated in Steven Johnson syndrome. There are many of them. Let me mention one. Allopurinol is there. Carbamazepine is also there. So mention the common ones. Where is Toro? Are you here? Saebi, Adetala. So I've mentioned allopurinol. I've mentioned carbamazepine. Also, penicillins. Penicillins are notorious, and sulfonamides. That's why there are people that have taken Fancida and have come down with Steven Johnson syndrome, right? So penicillins, sulfonamides, carbamazepine, anopiridol, some NSAIDs sometimes. Okay. Are you all here? Are you paying attention? If you can hear me loud and clear, say loud and clear. Write it, type it, please. Or I will keep going. Okay, Esther said loud and clear. Okay. Is it only Esther that can hear me? Okay, I said also wrote. Okay, fine. Okay, very good. All right. So we'll keep going. The next question is on fungal infections. What is fungal nail infection? What is it called? Someone should write it. Fungal nail infection. What is it called? Fungal nail infection. What is it called? Did anybody answer for me? Fungal nail infection. I'm waiting. Uh, Esther, are you there? What is fungal nail infection? Because you people said that you were taught fungal infections a lot. It's one of the things that they asked a lot. So please answer. Okay. Maybe I should step in. Okay. So fungal nail infections are called. Maybe I should just type it. On Nico, Nico, Michael. So I've written it. You see it. Fungal nail infections. Uh, I thought I typed something. Why is it not appearing? Let me type again. Okay, it failed to enter. Send. Uh-huh. So you see there, onychomycosis, that is fungal nail infection, and is basically caused by the dermatophytes, like the Trichophyton rubrum, right? It can also be caused by Candida. So, and the best way to diagnose those kind of patients is either you cut the nail clippings, or you do scraping of the affected nail. And the best treatment for that is you give terbinafine, and also you can give itraconazole. Terbinafine and itraconazole. So that's the treatment for onychomycosis. That is um, fungal nail infection. Please take note of that. Okay. So let's go to the next. So as I earlier said, Lachum planus affects the flexor areas of the body, of the arm and the forearm. It also affects the sole of the foot and the palms of the hands. There is a particular pattern. I don't know if they taught you in your class that Lachum planus give, like white lace pattern. You know, like lace now, women will know this lace something. So like white lace pattern. So it can give you that. Okay. Which is called which hamstria. Okay, Saibi, I said the drug for onychomycosis is tabinafine or itraconazole. Let me, which I try sending it. Let me see if it will come. Uh, Sorry, let me take something. Cancel. Okay. Saibi, I've typed it for you. Hmm? So I was talking about latching planus affecting the flexor areas of the arm and the forearm, affecting the sole of the foot and the palms of the hands. It also has a particular pattern called the white lace pattern, which is also called which hamstria. Let me even type it. Because the way they ask you question, I will not say this is more than your level before somebody will come and ask you and you miss it. So it's better I just anything that I see that is important. So people with latching planners can have witch hamstria. That's the white lace pattern. Okay. And the treatment of latching planners is just steroids actually. But there are drugs that can aggravate latching planners, that can make a patient to develop latching planners. And they include quinine, they include thiazides and gold. Quinine, thiazide, and gold. So these ones they can cause an individual to have latching planus. There is K in between it. Let me correct it. Which um, all this English name, voila. Okay, so let's go on. Were you taught the different treatment plans, treatment for psoriasis? Were you taught the different treatment plan for psoriasis? Yes or no? Please write. Saibi, were you taught the different treatment plan for like giving steroids, like giving systemic treatment, like methotrexate? Okay, so you were taught. So you can use steroids either as topical or oral. You can use shampoo, especially if it is scalp psoriasis. You can use methotrexate systemic treatment like methotrexate, cyclosporine, retinoids, and even you can give biologic agents like infliximab and adalimumab. So all these ones are treatment plans. And there is also opportunity for phototherapy where you use ultraviolet A light, that's PUVA. So you use Soraline plus ultraviolet A light, that's PUVA. PUVA means P is Soraline, the UVA is ultraviolet A light. Okay, so you can use PUVA to also treat psoriasis. So steroids, which could be topical, mostly topical. You can use shampoo sometimes if there is, together with the steroid, if there is scalp psoriasis. You can use phototherapy. You can use systemic therapy, which I've given you some of the examples. But sometimes for chronic plaque psoriasis, we'll discuss the types later. You can use coal tar also. We'll go to where we'll discuss the defining features of each type of psoriasis. This is just giving you a highlight of the treatment. Okay, there are some things that if I see it, I know it's above your level. So we are also back to our fungal infections. Okay, what is fungal infection of, or let me put it that way. What is the dermophyte fungal infection of the scalp? Dermophyte fungal infection of the scalp. What is it called? Dermophyte fungal infection of the scalp is called what? It's called tinea what? Let me give you a hint. Dermophyte fungal infection of the scalp is called tinea what? Has anybody written it? Okay, very good. Esther is tinea capitis. That's of the scalp. How about of the trunk? So me, I'll answer my Tino. So if it involves the trunk, leg, and arms, that's the tinea corporis. If it involves the feet, that's tinea pedis. Pedis, pida edema. How you remember pedis, like when you are saying pida edema. Okay? So, and the treatment generally is you giving antifungal. Antifungals like terbinafine, and also, but the antifungal you're given depending on the species. What are the two species? Please remember, is the Trichophyton species and the Microsporum species. The Trichophyton, the best treatment is the terbinafine, while for the Microsporum, the best treatment is grisofulvine. So Trichophyton is terbinafine, Microsporum is grisofulvine. So which of them, is it Trichophyton or Microsporum that will give you that green fluorescence under woodland? You know, that's one of the examine. Apart from scraping to do culture, you can examine under woodland fluorescence or fluorescence under woodland. So which one gives you that fluorescence under which woodland, and which one does not give you? Answer now, please. So which one gives you fluorescence under woodland? Is it the trichophyton or the microsporum? I hope you were taught. Let it not be that I'm asking things that you were not taught. Uh, so Abi, Aishat, Haruna, Adetola, I did not hear you today. Oh. Okay, SSA you were taught. So let me. Okay, very good, Sahibi. So the microsporum is the one that will give you green fluorescence under woodland, right? Why the trichophyton do not do that. So the best thing, since there is this difference, the best thing is just to do skin scraping and do a fungal culture. That's but the fluorescence will just give you an idea on the type of organism that is responsible for the dermophyte fungal infection. Okay. Please, if you are with me so far, say we are with you, sir. If you have question, please ask. Let me not be running more than my shadow. If you have question, please ask. If you do not have, say we are with you, sir, so that I can continue. You know, dermatology is not easy, so I can understand it can be difficult to comprehend. It only stays with practice. Okay, so all right, thank you. So you're all with me, so it's okay. Let's go then. I'm trying to find things that are relevant to you with the hope that nobody will go during your exam and be asking you things that did not teach you. Okay, let me do a little test of let me do a little test of knowledge. Where's my hotspot? Let me do a little test of knowledge. What are the drugs that can cause uh, lichen planus? What are the drugs that can cause lichen planus? I said it earlier. Who will answer? Okay, gold, quinine, very good. And what again? Thiazide. All right, thank you, thank you. I'm happy you people are with me. Okay, very good. Thank you. Thank you. Okay, so I saw that Sahebi, but were you taught the difference between the toxic what is it called, necrolysis or whatever, Saebi, were you taught and was it asked during your exam? I told you new things will be very difficult to be asked. So I don't want you to fill your brain with too many things. Gani, were you taught? If you are taught, then we have to discuss the simple way. Okay, there was an oral question. That's serious. But this, anyway, let me try and make it extremely simple for you people because I don't expect that they should ask you people, but since you were taught. So the Stephen Johnson syndrome and the toxic epidermal necrolysis, they are almost the same. Uh, they are the same thing. The main thing is the severity. The major thing is the severity. Nothing less, nothing more than that. They are virtually the same disease. It's just like for you to tell me insulin, what's the difference between insulin resistance and type 2 DM? Right? It doesn't make sense. So if it's Steven Johnson's, you have the skin detachment, areas of skin detachment, the epidermal areas that the skin detachment is less than 10%, right? But if it is toxic epidermal necrolysis is more than 30%. But there's even a spectrum in which you have the Steven Johnson or SJSTN overlap, where the area of the skin detachment is between 10 to 30%. So if I was the one that was asked this question, I would say they are virtually the same disease because the toxic epidermal necrolysis is the severest form of the disease. If you say that, you are finished, you are finished the answer because they are not inseparable. They are just one and the same thing. So, Saib, I hope I answered your question. Okay, were you the one that was asked the question, Gani? Eh? Answer me now. Are you here? Okay, it was Anna's bar. So they are the same thing actually. It's just that it is the tan is the severest form of Stephen Johnson's, right? Because told you that Stephen Johnson is less than 10%, while toxic epidermal necrolysis is greater than 30%. Okay, and of course the fact that tan is greater than 30%, it has more mortality than Steven Johnson's, which is expected anyway. While Steven Johnson is centrally located, a type of erythema, tan is generalized, still is pointing to the same thing. It's a spectrum. There's even a condition where you have SJS tan overlap. So the answer is while Steven Johnson is the beginning of the spectrum, right? Tan is the severest uh, uh, part of the spectrum. It is just based on the area affected and the severity of the symptoms. If you say this, you have answered the question. So let's go ahead. Okay, so we have talked about scabies and the treatment, and I told you that people at risk are people that are in close contact with those people, household that are overcrowded areas, prisons, and other things. Okay, I've said that. So let's forget about scabies. Let's see if we'll see another thing that you have likely been taught. So, what are the extra dermatological complications of psoriasis? Psoriasis can give you psoriatic arthropathy. It can increase the risk of metabolic syndrome. It can give you cardiovascular disease. It can give you psychological distress. All these ones are possible issues that will come with psoriasis. So, which one is the most common type of psoriasis? We are on psoriasis now. Which one is the most common type of psoriasis? Somebody should write. Most common type of psoriasis. And remember, I said psoriasis affect the extensor surfaces, while lichen planus affect the flexor surfaces. So which one is the most common? Okay, so let me answer. Please pay attention, right? So, okay, somebody have written something. Okay, so the different types of psoriasis, we have the plaque psoriasis, you have the flexural psoriasis, you have the gout psoriasis, you have the pustular psoriasis. Okay, so the plaque, the flexural, the gout, and the pustular. So the plaque psoriasis is the commonest type of psoriasis, and you see it as well demarcated red scaly patches affecting the extensor surfaces. So the goated psoriasis is the one that is just like teardrop lesions, the way they taught you in hematology. So goated is the one that gives you teardrop lesions, while pustuli like pustules, right? So, but the commonest type of psoriasis is the plaque psoriasis. Please do not forget. So we have plaque, we have flexural, we have goated, we have pustular. Okay, please do not forget. So, what are the factors that can worsen psoriasis? Please pay attention. Factors that can exacerbate psoriasis, right? So, one is trauma. If the patient has trauma, right? Alcohol intake, then drugs like beta blockers, lithium, anti-malaria like, excuse me, chloroquine, NSAID, ACEI inhibitors, or you do withdrawal of systemic steroids. So this can trigger psoriasis. Remember, we said for lichen planus is gold, thiazide, and quinine. For psoriasis, we are saying is trauma, alcohol, drugs like beta blockers, lithium, chloroquine, NSAID, ACEI, or if you withdraw steroids. Okay? Yes, be teaching you. Were you taught Kopner phenomenon? Let me type it, then you answer me. Kopner phenomenon. I've sent it. Okay. Were you taught? Okay, you have already answered yes, sir. Okay. So Kopner phenomenon is when skin lesions appear in the site of injury. So what are the diseases that can give you Kopner phenomenon? Any ideas? Anyone that you can remember, then I can complete it with the other ones. Any ideas? Psoriasis is good. Esther, any other one? Psoriasis is there. Okay, I said psoriasis. All right, thank you. Any other one? I need another one apart from psoriasis. Saibi. Ah, Adetola, are you sure you are with us? I've not seen your write up. Oh. Okay, so let me answer the rest. So apart from psoriasis, pay attention. There is vitiligo is there also. Lichen planus is there. Lichen sclerosis is there. Then molluscum contagiosum. Let me repeat. Psoriasis, vitiligo, lichen planus, lichen sclerosis, molluscum contagiosum. So these are the diseases that follow the Kopner phenomenon. Hope that has increased the things you know. Okay, I taught you about nail infection. Okay. Why you taught contact dermatitis? Why you taught contact dermatitis? Why you taught contact dermatitis? Gaskiya, I expect that you were taught, but let's see. Kindly respond, Esther Aishat. Head died 2 days ago. On examination, he has a weepy vesicular rash around his hairline, uh, but the scalp is not affected. What is the likely diagnosis? So this one, he had a dye some 2 days ago. Now he's presenting with a rash on the neck and the forehead, and also some vascular rash on the hairline. What do you think the patient have? Is it allergic contact dermatitis or irritant contact dermatitis? Is it allergic contact dermatitis or irritant contact dermatitis? Okay, I shall say allergic contact dermatitis. Any other one? Any other person? Okay, Isa Yusuf. Yusuf, you are around? This is the first time I'm seeing you now. You have not been active. So, of course, yes, it's allergic contact dermatitis. What do you know about allergic contact dermatitis? It's usually caused by if somebody has had dying of his hair. And secondly, allergic contact dermatitis usually affects the head. while irritant contact dermatitis usually affect the hands. The hands is usually for head is usually for allergic contact dermatitis. Please don't forget it. So this is allergic contact dermatitis. Allergic the head, irritant the hand. So don't forget that, please. Okay, so the next question is a 25-year-old male presented with a patch involving his the involving his front, back, face, and thighs. So it's a bit widespread. Hmm? So he presented with extensive patch, right? Involving his front, his back, his face, his thigh. There's mild, the pruritus is just mild, right? So the pruritus is just mild. And there is scaling also. What do you think is the diagnosis? So hypopigmented patch in his on his trunk, on his face, on his back, on his thighs. It is scaly and there's some small itching. What do you think is the diagnosis? I'm going to give you 30 seconds to answer, then I'll answer. Okay. Uh, okay, I've not seen answer. So this is pityriasis vesicular. Pityriasis vesicular. Yes, Saibi. Very good. It's pityriasis vesicular. Is the one that will give you this, and you treat it by giving terbinafine or selenium sulfide. But in severe cases, you can give oral itraconazole. So you give terbinafine or selenium sulfide, but in severe cases, you can give itraconazole. So it's the one that gives you this kind of hypopigmented patches on the face, on the back, on the trunk, and other places. Very good. Okay, so let me see. Uh, let me see if there's anything that I know should be undergraduate. Is latching planners, we have discussed it in detail. This is hope nobody asks you skin lesions that you see in. I don't think you were taught in diabetes. It should not be your business. It should be the business of my residents. But for your knowledge, the skin lesions you see in diabetes, there is necrobiosis lipoica. Okay, my phone will shut down. Plug. Let me try and plug before. So there is okay, you were taught skin disease and diabetes. That's serious. Okay, so I said necrobiosis lipoidica is there. There is also candida infections, so you can see oral thrush and other things. They can also people that have type 1, they can have vitiligo. They can also have lipoatrophy, especially type 1 that are on insulin. They can also have granuloma annulare, which are popular lesions with depressed center. So these are the basic things that you see in diabetes, but including acanthosis nigricans. So they taught you skin changes in diabetes. You people, Okay, okay. Isa Yusuf, your network is bad. That's why this kind of class. Anyway, after the class, you try and watch it. It's usually on my channel. You can watch it again. For those who have a network challenge, you can watch it again later. So that I'll make sure I don't delete it so that you go through it. So Esther, you got it, ba? I said necrobiology, biosis, lipoidica, granuloma annulare, vitiligo, lipoatrophy, acanthosis nigricans, and other things. But these ones I mentioned, they're the common type. Okay. So, Shaibi, Esther, Aishad, is there any aspect of dermatology that we have not touched? I tried my best to go around what I expect that you should know. But is there any aspect that we did not touch so that we'll see if I have questions or if you have questions? Because I like discussing things using questions, not just talking. Okay. Okay, Esther said no, sir. At least Esther is satisfied. Any other person that has any question, I'll do my best for us to create time to talk about diagnosis. As I said, you people know how to clerk, you people know how to examine. But if you clerk and examine and you do not achieve diagnosis, uh, there's nothing anybody can do. So, is there any question? Aisha, Saibi, Esther. Okay, Esther said no. Who again? Adetola and the rest that are joining with one phone. I've tried my best to cover everything. Okay, Aisha also said no, sir. Saibi, give me a response. Then who do I expect response? Yeah, Saibi. Saibi, are you online? Give us your response so that we can conclude. Isa Yusuf, you there? So you know, I don't know. Next week is Christmas. Uh, Let me see if I can create time. But for now, Saibi, it's enough for the MCQ and theory. It's the MCQ and theory. I want us to have, especially short case, what is expected of you. Though they are teaching you drill, but there's a, if you do drill, right, you get your findings. How do you harness it to make diagnosis and talk? Because even if you get the findings, if you don't talk, there's no way an examiner will pass you, right? Like someone examined perfectly, it's a facial nerve, perfectly. And he was saying facial nerve, but I said, okay, please, which type? It was obviously upper motor. He was saying lower motor. And a more senior examiner, my teacher was there. I cannot say no, it's upper for you. So automatically by saying that there's nothing I can do to help. You understand? So it's one thing to do an examination and to get your findings, another thing to harness it. Me, anybody that meets me, okay, I'll be stimulating you to talk. But if you do serious fumbling, that's nothing I will say because I'm not the only one there. So I cannot be seen to be biased. So it is very important that you know how to harness your finding. Me, I didn't have any problem with the way you people examine. You know how to examine, but it's achieving diagnosis. So I will try before your clinicals that we organize a session in which we discuss how to make diagnosis, how to give differentials, how to investigate those differentials. There are two types of examiners. There are examiners like me that if you make a diagnosis, your investigation will be based on the diagnosis you have made. But there are other examiners that want you to investigate with the differentials. So we'll talk about those things. So we'll see. Gani, get my number from Adetola. Okay, so that we'll see if there's a way we can create before, since your clinicals is it 6th January. Definitely we'll have time to discuss the clinical, at least 2 3 sessions of discussing the clinical. I think it will not be bad. Do you all agree with that? If you agree with that, let's do democracy. Say yes sir, yes sir, yes sir. Let it not be like is Saebi that is imposing his view on all of you. Do you agree with that? That we should have session before the clinical on the, and this is a strong word of caution. I need answer so that I can plan my time. Okay, Aisha say yes sir, Toro say yes sir. Okay, 3 years. Okay, I'm fine with that. Okay, so please read well, follow all your lectures and read, and any clarification you need, please, my contact is available so that you can reach me and I can make such a clarification. So make sure, unless those who are close, uh, maybe those who are in Jos or whatever, you go to your home for 2 days and come back. So I wish you all the best. I wish you a Merry Christmas, and try and do your best. Try and remove all anxiety. I think it will be well with all of you. So take care. Additional, thank you for joining. Sir AB, well done. Abdullah Toro, thank you for being here. Isa Yusuf and the rest that joined with Sir AB's phone, thank you for joining. I hope the sessions that we have had over the last, is it 2 weeks, have been profitable to all of you. I did not waste, I hope I did not waste your time, that you have gained one or two things that will help you in your exam. So all the best. Take care of yourselves. Good night. Good night, everybody. Thank you, Esther. Merry Christmas in advance to you too. All right.